So yeah, I don't know if anyone remembers the exact site, but I remember talking about oral versus parenteral, and what affects the drugs, what impacts how drugs are absorbed if we do give it orally. Now, if part of it is the drug size, if it comes as a large capsule, is it a liquid? Part of it is also the motility, GI motility. If it's lipophilic versus hydrophilic, because again, the nature of the intestine is a hydrophilic environment. It has to get absorbed, cross the membrane, get into the bloodstream. So some drugs are designed for quick absorption. Some drugs are designed for a delayed absorption, which we've kind of talked about. Now, when we talk about parenterally, because you're giving this, via injection, tissue blood flow does have a role, and the hydrophilic nature of the drug. Because again, if you're giving it intravenously, if you're giving it in the muscle, sub-Q, which those are not necessarily a lipophilic environment, that's also going to affect absorption. Temperature at the site. So I've talked about this when I've talked about fentanyl patches, but also again, heat in an area is going to dilate vessels, which can increase absorption rates. And sometimes, the blood flow to an area, if you don't have great blood flow to an area, that's also going to delay absorption. I don't know if you guys remember when we did the pain management lecture and I talked about in the horse, sometimes when they will do like a local block, they'll mix it with epinephrine. And because epinephrine locally will constrict the vessels, it can delay absorption because the vessels are constricted. So there's so again, if you can alter, sometimes in certain situations, heat is applied because we do want to increase absorption. And sometimes we, a cold pack or giving vasoconstrictive local drugs can delay absorption. So blood flow, the nature of the drug. And then once we talk about the drug is in, how it's distributed through the tissues. And the goal, when we talk about that, physiologic movement, you give the drug, it's got to travel through the tissues to the target, whatever the drug is that we're giving that. And again, that's the goal. What's the goal of distribution? It's right under here. It's to get to the target tissue. When you give a sedative in the muscle, the brain is our target tissue, right? We want to sedate them. So it's got to get from the muscle. And, I've kind of helped you guys on some surgery days. And I, informally, I can tell you, I feel like when dogs are given an injection or cats in the epaxial muscles, they go down quicker than the ones that get it in the back leg, in the semimembranosus and tendinosus. And, I think better blood flow, better muscle belly, sometimes that affects the rate of absorption. So, and that just comes from doing it enough. Is that an official study? There could be a study out there. I just know when I do it this way, they go down like this. When I do it this way, they go down like this. So that can impact. So what happens? We've got membrane permeability, tissue perfusion, which I've kind of alluded to, protein binding, and the volume of the distribution. So you have to get to the target by crossing cell membranes. You have to get through membranes in different areas to eventually make it to the target. Now, the membrane permeability, if you remember, and this I said in anatomy, a blood capillary, so drugs don't diffuse from an artery to the tissue. They don't distribute from a vein to the tissue. When you give something, when something enters the bloodstream, it has to reach the capillary. The capillary is 1 cell thick, and it has tiny little holes called fenestrations. That is where perfusion happens, or permeate. So oxygen diffuses at the capillary, wastes come in and out, nutrients, and eventually the drug is going to distribute from the capillary to the tissues, but it has to be at the capillary level. Now, we've talked about these membranes before, these capillaries, that the holes are only so big. If you think of it like a strainer, if I pour, and I've talked about this in the nephron, but you remember I said when things get filtered in the nephron, they get filtered through the glomerulus. But say I have a strainer and I have a can of tomatoes and I dump the tomatoes in the strainer. Well, obviously the juice is going to make it through the holes, but the larger pieces of the tomatoes stay in the strainer. Well, if you think about these capillaries and these little fenestrations like holes in a strainer, certain things can fit through and certain things are going to stay within the capillary. So the bigger, larger molecules, which are things, like albumin, which is your primary protein, your blood cells, now some drugs aren't designed to get through, can't readily pass through those membranes. They can't go through those fenestrations. That's why when I talked about anesthetics, and I talked about protein-bound anesthetics, if a drug molecule is attached to a protein, it doesn't fit through that strainer or that capillary. So we know that some of the drug I give is going to bind to protein and some of it's going to be free. Well, whatever's free to pass through the capillary is going to make it to the brain. What is bound is going to stay within the blood. So I know when I formulate a dose for an animal, some of that drug is going to go to the brain and some of that drug is going to remain in the bloodstream. Now, the practical application to this is what I've told you guys. When you have an animal has a low protein, low albumin, and they're lacking protein, I need to adjust my dose because in theory, if I give a normal dose, there's not enough protein to bind to. The animal has a low protein. So that means there's more free drug. Hence, we could get, overdose or get excessively deep. You have to take that into account. Now, I did say, we talked about this in anatomy, the blood-brain barrier. So the capillaries in the brain are a little bit different as, they do not have the fenestrations. They have glial cells. It's like little things that cover those fenestrations. So any drug molecules that leave have to be very lipophilic because they can pass through easier. But again, propofol is an anesthetic that's highly lipophilic. It's designed that way to allow for it to make, to get through that fenestration to make it to the brain. So that's a way to take a drug, make it in a certain, lipophilic way so that it can penetrate the brain, that blood-brain barrier. There is also a note, the capillaries in the placenta. We talk about an animal that's pregnant. We talk about drugs that, some drugs and a lot of anesthetics can pass whatever we give the mother. It's going to enter fetal circulation and they are going to be permeable. And again, anytime there's fever or inflammation and that causes swelling, can alter that blood-brain barrier, can affect the drugs. So areas that have barriers, blood-brain barrier, the eye, prostate, and placenta. And sometimes when animals have disorders in these areas, sometimes it's hard to give treatments because some of the drugs, you have to pick certain drugs that can permeate these areas because there is that extra barrier. I talk a lot about perfusion and what is meant by tissue perfusion. It affects how drugs will be distributed. Okay, so perfusion is blood flow or the amount of blood supply to an area. So if you get blood to an area, you have perfusion. One of the reasons you guys check a CRT, press the gums, are they pink? Does it come back? That tells you have blood flow, adequate blood flow. And so blood pressure, looking at gum color, feeling pulse quality, how can blood getting to the tissues and blood permeating or getting through and perfusing is key. So it can vary via the species. Now, one thing that affects your perfusion is vasodilation and vasoconstriction. So, for example, I talked to you about a lot of the anesthetics cause vasodilation. And when you cause vasodilation, you can decrease blood pressure. Well, blood pressure is part of how blood gets to those tissues. So you do worry about a drop in perfusion. That, you know, one of the big consequences of having low blood pressure during anesthesia is it's going to affect perfusion to the tissues. Consequently, when you have vasoconstriction, and we talked about vasoconstriction, you know, like you give dextromethorphan, you have vasoconstriction. If you look at their gums, their gum color, and feel their pulses, a peripheral pulse when they're on dextromethorphan, you know, sometimes it's harder to feel a pulse. Sometimes they're a little more pale because those vessels are vasoconstricted. So you do have, I mean, you still have blood flow, but it's going to alter the flow to that area and how drugs could be absorbed. So the protein binding, and like I said, I like to talk about this. Some drugs, now there are drugs that are known as highly protein bound and not as highly protein bound. But like when I talked about propofol, propofol is a highly protein bound drug, has a high affinity to bind to protein. But we're talking about albumin as the primary protein. It cannot leave. So I like this picture here. So here is a protein and the X is the drug, and it's, you know, binding here. And then you've got this, here's a capillary. Endothelial is the inner lining of the capillary. And so you have these one cell and you got these little gaps, but you can see that whatever's not bound, I'm sorry, so the X is the protein. These are bound. These are free. So when it reaches the brain, the free drug leaves, penetrates the brain, animal becomes anesthetized. So if it's free, it can go out. The protein bound fraction, the free fraction, is like the equilibrium of the drug. So some of it's going to bind to protein and some of it's going to be free, and you achieve what's called equilibrium. Okay. Now, if you lower the amount of protein, you get more free drug. We're not in equilibrium, and more drug can leave. So there's a lot of notes under here about this, but it gets trapped in circulation. And what I've explained here, there's a note, recommended doses for protein-bound drugs are designed to compensate for the amount of protein. When you have a dose of propofol, which our normal range is 4 to 8, well, that'll use it BCA, 4 to 8 mg per kg is a range. That dose range accounts for a normal protein. Again, if you have an animal that has low protein, you can adjust that dose. I've always said you can use lower amounts. You may have to give more, but you're better to kind of undershoot and have to give more than give too much. So you can, you know, there is a storage pool of the drug. So what can happen as propofol is uptaken in the brain, and then some is in the bound, it's going to continue to circulate. Some will be excreted, and some can be free again. They can kind of like let it go, and it can stay in the brain. There is a note here about liver disease. I've told you the liver produces proteins. So the other thing is, now obviously part of your blood work is to take a protein level. It's part of the chemistry panel. But you can also sometimes assume, if we're worried about liver disease, we worry about clotting factors. We also worry about protein levels. Because again, low protein, and you end up giving a normal dose, you have a higher chance of side effects or a more profound effect. Now, volume of distribution, how well is it distributed based on what is in the blood? So this assumes that the drug in the blood is equal to the drug concentration that's dispersed in the body. So if you think about on this picture here, you've got fat, blood, which is your plasma, extracellular, intracellular. So these are the spaces. So when we give a drug, obviously, so if we give something intravenously and we're giving it in the blood, at first, there's really nothing in the fat, extracellular, intracellular. We first give it in the blood, but as you give it in the blood, that drug is going to redistribute. It's going to distribute to different compartments. Now, again, sometimes, it depends on the type of drug that we're giving. If you're talking about a lipophilic drug that has maybe more affinity, some is going to be in the blood. But remember, things always want to go from high to low. Okay, so some of that is going to go to the fat component. Sometimes it's going to have a higher affinity for a different area. But that's kind of what we're talking about, the volume of distribution. Where is the drug moving in the different compartments? So the volume, if you think about the overall volume of the patient, the larger the volume of distribution, the lower the concentration in the blood after distribution. Because again, once you give it in the blood, it's going to distribute. So in this example, it says a dog with ascites has a greater volume of distribution, results in less concentration in the blood and other tissues. So ascites is when they have fluid in their abdomen. So if they, now think about it, in a normal dog, they have very little fluid in their abdomen. If they have a large amount of fluid, when you first give a drug, it's going to have, there's a larger component of fluid, which is going to cause a larger movement of drug from the blood to that area. So therefore, because again, when you give a drug, you're accounting for certain amounts. So again, it may cause, us to change our dosing. For example, now there's a math example in this, Gray. Don't worry about that. I just want you to understand the concept. But again, if you have a dehydrated dog, will have a decreased volume of distribution. So when you give that drug and they're lacking fluid in that like extracellular space, right? You don't have that fluid component. So you're going to have more drug potentially to stay in the blood or to redistribute to another compartment because that fluid component has a lower volume, right? So we have to look at, if we have animals with ascites or dehydration, do we, and this is up to your doctor, do we alter the dose to account because one of those areas has a lower volume or a higher volume? That can affect our dose. Okay. And biotransformation, which if you think about this is the metabolism. Biotransform or transform, you're changing it. So you can also think of it as inactivation or detoxification. So when you give a drug, the drug has to leave the body somehow. Now, some drugs, can potentially get excreted as what we call active. So like when I talked about ketamine in cats, about 90% of ketamine gets excreted as active drug. So 90% of it didn't get biotransformed. It didn't get inactivated. It's technically still active when they excrete it. So again, if there's a problem excreting it, in theory, you have more drug available for excretion. Now, when you have the chemical alteration, we talk about you're going to change it into what's called a metabolite. And this is what I just talked about. Some metabolites can be active. So again, ketamine in the cat, 90% of the metabolites are active. It's not been altered or rendered inactive. The majority are going to be inactivated. So it goes to the liver, it's transformed, changed, and then when it's leaves the liver to be excreted or maybe sent to the kidney or it's in the blood, it's been broken down. Now it's not an active drug. Can potentially turn into a toxic form. So toxic metabolites we worry about. But there's enzymes that actually work on the drug and alter the chemical makeup of the drug. And that changes its properties. So biotransformation or inactivation is the body using the enzymes to change it into another form. So if a metabolite is more hydrophilic, so again, if it was biotransformed from lipophilic to hydrophilic, then it doesn't have, say, the affinity for fat. Where's my note here? Sorry. these slides. Okay, so for example, if it's hydrophilic, it doesn't have the high affinity for fat. If it can't go hide in the fat or be sucked up by the fat, then more than likely it's going to be sent from the bile to the intestine or to the blood flow to the kidney to be excreted in the urine. Because really that's the two primary pathways that drugs are excreted, either through the bile to the intestine or through the urine to the kidney, or to the kidney to via the urine, and they're excreted. So those are, because they alter the makeup, they don't get reabsorbed in the fat and they end up getting excreted. So if you biotransform them and they're more water soluble, then they can be actively excreted from the body. So the biotransformation, little bit, is you can have oxidation reactions. You lose, the electrons. Remember I told you there's either positive or negative charge to these hydrophilic molecules. The hydrolysis, adding waters, to molecules to cause a drug to split. So these are just different ways that what they're basically doing is they're taking that drug. Now say again, like a drug like propofol, or, that's lipophilic. If it gets altered to make it hydrophilic by one of these reactions, then it can get excreted. Therefore, it doesn't get reabsorbed by the fat or keep causing anesthesia. You get rapid recovery. So the majority of these enzymes that are found in the liver, because remember, the liver, kind of like I said, I call it the HEPA filter, is where the majority of these are found. Some in the kidney and some other tissues, but the majority of biotransformation happens in the liver. One is cytochrome P450. That's one of the detoxifying enzymes, and that lives in the hepatocyte. So in the cells of the liver, you have this enzyme that will break it down. So now there is a note, I'll put in, read this to you down here. And I remember I have taught pharmacology once, but when we talked about phenobarbital, and when animals are put on phenobarbital, usually long-term for seizure control, it can cause an increase in biotransformation. So when that drug is given, increases that biotransformation of the drug. So what ends up happening, the owner gives the same phenobarb, daily, and the liver is, like we talked about it, kind of, they get used to the drug. So it reduces the patient's response. And so a lot of times the drug must be increased to get the same response. So when an animal, the practical application to this, when we give an animal phenobarb, and we usually put them on a dose, and then they usually come in for blood work, and we do what's called phenobarb levels. We'll test the level of phenobarb in the blood, because if we see that that has dropped, the liver is doing this accelerated biotransformation. Sometimes we have to increase that dose. So, it's not like you just put this dog on the pill and be like, see ya, we don't see you for a year or two. It's really, because what happens is if the owner gives that amount and then it's not as active, then you have the likelihood the animal could, experience a seizure. So, there is a normal blood level of phenobarb that needs to be consistent to keep seizure control. If that drops, you have a likelihood an animal can have a seizure. So it is recommended that they come in periodically to check levels of this drug to make sure we stay at a consistent amount. Now, drug interactions is something, sometimes when you give drugs, and we talk about synergism, when two drugs can work together, because we do worry about interaction. So, for example, altered absorption, one drug can alter the absorption of other drugs. Now, there is a note here about antacids. When you give an antacid, So if the patient's on Pepsid, for example, and that's changing the pH of the stomach. That's the job of the antacid, or decrease the acid. Well, if you change the pH of the stomach and then you need to give another medication, then what's happening is it can alter the way the other drug is absorbed in the GI tract. So sometimes, and I stress these little notes because sometimes you have to explain this to the client. Sometimes we separate when medications are given. There's a lot of medications we can give. If we have a patient on GABA and Rimadyl and Tramadol, a lot of times we give all three at the same time because they don't interact with each other. But if we're potentially using a drug like sucralfate or an antacid that's kind of altering the stomach environment, sometimes we'll separate those drugs from other medications because, and again, and this is a doctor call, but my doctors will write instructions, give Pepsid, give other medications an hour later, or give, this and then give this medication. So sometimes drugs do have to be separated, not all given at once due to these interactions that can affect the metabolism or the uptake of that other drug. Now, competition for proteins, sometimes one has a high affinity and displaces the other. So if you give two drugs together and one binds to protein stronger, and then the other one's like, wait, I need to bind to it too. And the other one's like, well, I'm already here. If you think of it that way, so if they're competing for binding, you give two protein bound drugs. Well, if one binds, then that other one becomes free drug, right? If they both can't bind at the same time. So the other thing you worry about is, would you cause a toxic level of the other drug because they compete? So that's the other thing. It's like when you prescribe medications, we need to make sure that they're not going to interact. You can get altered excretion. Now, for example, if we talk about the kidney, and if we talk about drugs that act on the kidney that can increase or decrease excretion, for example, diuretics. If we remember, we talked about a drug called Lasix or furosemide. And a diuretic is increasing urine production. It causes body water to be excreted at the kidney. So a lot of times animals, we might have an animal in congestive heart failure, and a lot of them can get like fluid on the lungs, or they get fluid in the tissues, they get edema. And the patient is put on a diuretic to try and pull that fluid from the tissues and get it excreted. Well, if I'm giving a drug to a patient that causes that diuresis, you're accelerating movement of water to the kidney, could alter the excretion of other drugs. And maybe there's drugs we don't want readily excreted. So an animal on a diuretic may have to, you have to look at the other drugs that patient is getting. Is that diuretic affecting the other drugs and causing an increase? Now, if you talk about altered metabolism, that if the same enzyme is needed to break down two drugs. So if you give two drugs and that enzyme's like, well, I have to break down both of you. So you got two drugs that both have to be biotransformed, because if they're given to the animal at the same time, then you can get the altered metabolism, because the enzyme can become saturated, and what happens is, because it's working on both drugs, you're having an altered breakdown of those drugs. You're not having one work on just one drug. So you can get, if they're broken down more slowly, not as rapid, you can see potential toxic side effects, because it's not being excreted at the rate, or it's not being broke down and excreted at the rate it should be, because there's competition for that enzyme. Therefore, slower breakdown, slower excretion. Now, if we talk about, drug interactions and the effect on that metabolism, so the liver has to be able to metabolize the drugs that it gets. So we worry, is there any issue with liver function? If the liver we say if the liver is potentially, if we have any liver damage, or do we have an underdeveloped liver? So I like the cute little kitten picture. But, a neonate's liver is not mature, but this is typically under 5 to 6 weeks of age. So when it's probably rare that you're doing something to an animal that's 5 or 6 weeks old, but, their liver is not fully developed. So they're going to have altered metabolism of that drug because we're not having a fully functional liver. So a lot of times you have to lower the dose. But what about if we have, if we have a geriatric patient and we worry about their liver function, that if they're not producing adequate amounts of that enzyme due to liver dysfunction, then potentially we're going to reach toxic side effects of the medication we give. So those are situations, and I think the real world application also to this, when you tell an owner we have to do blood work, why are we doing blood work? The owner's like, my dog's fine, look at him, Well, you have to explain, like we're giving anesthetics or we're giving medications for a procedure or sending home medications. We have to make sure your animal can adequately metabolize and excrete these drugs. So it'd be nice to know, are we starting, because I'll guarantee you in that scenario, that's the animal that comes back sick, has elevated liver enzymes. And then you're like, did we cause the elevation in liver enzymes, or did the animal have pre-existing elevated liver enzymes? So again, I've talked about that in the anesthesia when we talk about patient history, but how do we justify why we're drawing blood, or why do we need to know if we have good liver and kidney function? Now, if we talk about tolerance, and sorry, these slides, maybe they'll open better for you. I'm just having a problem. That's a decreased response to the drug because of repeated use. In one of her previous slides, and I know Gillis used a drinking example, which I'm not, normally talk about drinking, but, there are people that drink a high level of alcohol and then, they say, wow, you develop tolerance because, they've drank so much that, it takes a greater amount of that drug, alcohol, to cause the same effect. Well, if we're talking about tolerance and we're talking about an animal, there's a metabolic and cellular. Metabolic tolerance, the drug is metabolized more quickly because of chronic use. For example, in phenobarb, the liver sees phenobarb all the time. That cytochrome is activated, it breaks it down, and it's kind of accelerated. So it kind of develops a tolerance. It's like, I've seen this drug before, I've metabolized it, and that's why we maybe have to increase the dose. And if we talk about cellular tolerance, when you have, decreased cellular receptors, so what you can happen is the receptors aren't as sensitive to the drug. So it can reduce the receptors, it can reduce their sensitivity. So if for example, if you give something that has to bind to a receptor and this receptor is not as sensitive, you're going to have to use an increase dose to try to, and that's also, again, from chronic use. Now, again, I think there's maybe some more examples of this in people abusing drugs and alcohol. But again, if you're giving a chronic drug to a dog, we have to think about this as well. Now, drug elimination, or getting it out of the body, you primarily think of renal and liver. Okay, so through the kidney and through the liver. Now in the liver, it goes to the bile, which is excreted in the intestines, which is going to become part of the feces. Or it's going to go from the blood flow to the kidney, it becomes urine, part of the urine, and it's excreted. Now you can also think about saliva and sweat can get rid of some drug. Now the kidney, again, balances that ADH and the water balance on how much urine it makes. And so part of that can affect how much is excreted. through the urine. Also the lungs. You guys are doing anesthesia. How do you eliminate inhalant anesthetics? They have to exhale it. And a lot of people spend time thinking about exposure to inhalants, and you think about like masking them down. There is quite a bit of gas anesthesia exposure and recovery, because when they're waking up, when you're sitting there over them, recovering them, they're exhaling this anesthetic. But if you think about the primary, is we're going to focus on the liver and the kidney. So we have renal elimination. Now, if you guys remember the nephron and that lovely nephron physiology, when blood in the body goes to the kidney and it gets renal arterial, which goes to an afferent, goes into the glomerulus, which is that capsule inside that nephron, and that's like the filter. So what happens is the body is kind of indiscriminate. Anything that's soluble or can pass through the fenestrations is going to get pushed out in the glomerulus. So some plasma, body water, nutrients, wastes, drugs. And then the glomerular filtrate is going to, it's going to be traveling through the nephron. Now, if you remember, the GFR, glomerular filtration rate, that's the rate that the filtrate is produced, depends on blood pressure. When I talked about the nephron ages ago with you guys, blood comes in under pressure. It's through the arterial system. But if we have, for example, if we have a hypertension or high blood pressure, it's going to increase glomerular filtration rate. Think about my strainer analogy. If I just pour my tomatoes in the strainer under just pouring it and I let it drain naturally, I'm going to get juice under the bowl, and some bits, the tomato bits, are going to stay in the strainer. But what if I push on those tomatoes? Now what do I do to the rate of production of tomato juice? Well, I'm going to increase it because I'm putting more pressure. Okay. And then sometimes the consequence is little bits can get pushed through those little holes. So when you have high blood pressure that comes into the glomerulus, sometimes you can get things like protein, which are not supposed to get pushed out in the glomerulus. They can actually push through because they're under higher pressure. Now, the note under here, it says what happens if our patient's hypotensive. So if you have low blood pressure, then you get decreased blood flow to the kidney. And then what happens is you have kind of vasoconstriction to the kidney. And then what happens is you don't get as much blood flow. So you get decreased elimination of drugs and increased within the bloodstream. So I literally just had anesthesia lecture and I was talking about this, was why blood pressure is so important to maintain blood flow to the kidney. Because again, if you don't get adequate blood flow, you get vasoconstriction. First of all, you're not getting adequate oxygenated blood to the cells in the kidney. But the second thing is, if you don't have blood flow to the kidney, you're not excreting anything, decreasing the urine production. But then if it doesn't get pushed out into the urine, because the kidney's not making urine, then where does the product stay? In the bloodstream. Potentiated effect, overdose, toxic levels, potentially. Now, if you remember, as it passes from the glomerulus, it goes into the tubular, the PCT, the loop of Henle, and the DCT. So then what happens is, if you remember, things can move. Sometimes things get pushed out in the glomerulus and the body was like, ooh, my bad. I didn't mean to push that out. It's not discriminate on what gets pushed out. So what can happen is sometimes the body wants to reabsorb something from the tubular filtrate back to the bloodstream. And that can be done via active transport. So again, this is something that does require energy, because something needs to actively move from the tubular filtrate back into the capillary. So any disease where they have a lack of energy or can affect that process, if they have lack of glucose, body condition, if you think about it that way. But also, a drug like penicillin says, why are penicillins used for UTIs? Um, Penicillins are secreted into the tubule, and it allows them to really, they can accumulate in that tubular uh, lumen and filter. And that's where we want to have that drug cause its effect. So if we have a note down here about the penicillin, is the drugs can accumulate in the nephron and filtrate, and then you have a high concentration at the kidney, which is going to the bladder. You have a higher concentration to, treat that UTI. So that's just an example of how you can use that system. Now, tubular reabsorption, there's notes about lipid solubility, passive diffusion, but basically, when you talk about reabsorption and you talk about the kidney, it's when the body wants to get something that's been pushed out in the glomerulus, and we want to move it from tubular filtrate back into the capillaries before it becomes urine, because once it's excreted, it's gone. So if the body wants to access anything back, then it's going to have to, absorb, So this is at the loop of Henle. You also can get some reabsorption at the DCT, which is the last part of the nephron. But this would be useful substances. We want, and also reabsorption of electrolytes and body water. Again, the body's constantly being monitored. If we need more water, if the animal's dehydrated and we want more water back, that happens usually at the loop in the DCT towards the end of the nephron. Now, we talk about hepatic elimination when drugs go to the liver, okay? The blood goes into the liver, and you have a hepatocyte, which makes bile. Bile is secreted into the duodenum. Now remember that bile duct connects, and so when bile is secreted into the duodenum, if you think about now, something that went to the liver is now in the intestinal lumen, okay? So if a drug is being eliminated, it goes into that bile fluid is secreted in duodenum. Now, if a drug that enters that lumen is lipophilic, it's going to get usually reabsorbed into the bloodstream and go back to the liver. It can get resent to the bile. Or if it's hydrophilic, it typically, part stays within the feces and then is excreted out. So you got the hepatocyte, the bile, talks about hydrophilic, lipophilic. Now, intestinal elimination, again, is one of the ways we talked about drugs being eliminated from the body. So if we're also talking about drug elimination, just a review of some of these terms, because you probably remember, and hopefully remember this from, obviously pharmacology, but maybe you've already talked about it in large animal. But when we talk about drug residue, is, the amount of drug that can be detected in the tissue at specific times after administration of the drug ceases. So every drug is, when it is made, it's like, and this really pertains primarily when we talk about food animal, we're talking about cattle and chicken and pigs, because if they get drugs and then they have to go to slaughter, you have to make sure there's no drug residues left in the meat. And that's what the withdrawal time comes from. So when we talk about withdrawal time, it's the period of time, there's a note under here, after administration with the animal cannot be sent to market, or eggs or milk must be discarded. That's the other thing, like a cow has to be milked twice a day. Or their udder is like, so a lot of times they're going to get milked. So if they were given an antibiotic, say they had, a wound and they were given antibiotics for a wound they got in the pasture, that antibiotic is going to have a residue time frame where it's detectable in the tissues, and then a withdrawal time. So how long from the time the animal stops getting the drug, can that residue not be detected and they can be sent to market. So again, this is a little bit, you know, and the FDA determines this. So when you use these drugs, we know, you know, for maybe 2 weeks, this cow is milked and you have to dump the milk. Cannot go into production. Because the thing you do worry about is if someone is allergic, if they're allergic to penicillin and they eat a hamburger and that came from a cow that there was penicillin residue in the muscles from being treated for an infection, then, you know, someone can have an allergic reaction. And we don't want to also worry about antibiotic resistance. If people were constantly exposed to low doses of antibiotic residue in product, could lead to antibiotic resistance in people. So things to think about. Now, when you talk about, you know, when they figure out the half-life of a drug, you know, the longer the half-life, the longer the withdrawal time. So, you know, if we look at a drug's half-life is 4 hours. So if you give a drug, what this tells you, oh, I'm sorry, JC, that stinks. If a drug has a half-life of 4 hours, when you give the drug, in 4 hours, only 50% of that drug is remaining in the system. Okay, so 4 hours means only half-life, half the drug is remaining in the system. Now, after 8 hours, so we do another 4 hours, 50% of that drug is reduced by half. So now we have 25%. And if we do another 4 hours, we have that, and that's 12.5%. So that's telling you that it's going to take, looks here, about 16 hours for that drug to be eliminated fully from the system. So again, and if you're giving it multiple days, then you know, but that's how, you know, that's how long that we expect that drug to be in the system. Now, steady state, the point at which a drug accumulation and elimination are balanced. So plasma concentration, half-life. You give 4 to 5 half-lives for this to be reached. Why is this? Drugs with a long half-life, loading doses are given. If you remember, I talked about sometimes we want to give a boost of the drug, give a loading dose to kind of reach plasma levels quickly. So if we look at this, you know, drug plasma, we give a maintenance dose and 5 times the drug's half-life, is we have to give repeated dosing and then we finally reach a steady state where we're, you know, maintaining a drug in that. This also kind of relates to therapeutic range. Oh shoot, it's 12:53. Let me stop here so we can kind of finish these last couple ones. Yeah. Let me. Okay. Do you have questions? I know this part of pharmacokinetics is kind of, but